Okay, I think we're live on CTisus. Today is July 31st, so there it is, you're now live. So, hello, I'll say that again. Today's July 31st. It's hard to believe, but July is essentially over and August is tomorrow. I noticed that it's supposed to rain today, a lot of the US, and then tomorrow the temperature for the next week will be no higher than 80 rather than being 100. I was in the car yesterday, it was 117 in the shade in the car. But, it's the summer, you can't be complaining. Hope everybody is doing well, and those people who started new jobs or new fellowships, new residencies, internships, or whatever you started is going well. Crazy medical environment, as you know, particularly on the academic side, but that too shall pass, one would assume eventually. Anyway, we're working hard trying to do all sorts of great things. Now, in terms of this week's topic, unusual small bowel pathology with CT, I'll tell you what made me think about it. We all know small bowel pathology. One of the most common applications of CT is rule out bowel obstruction, typically small bowel obstruction. We look for adhesions or a mass or a stricture like a patient with Crohn's disease. We do lots of CT scans where we look for the potential, studying the celiac and SMA and portal vein and SMV, for the possibility of ischemic bowel, very common application. Often rule out. We look for GI bleeds. We think about the colon and small bowel. We look for tumors. We work up anemia. But what are unusual? Well, the truth is, all small bowel stuff is unusual. You don't see that many tumors, primary or metastatic. But when I think about small bowel, the best case, it was a case I looked at yesterday, showed in conference to Linda Chu, and she gave a great differential because it looked like a mass of the terminal ileum with masses in the mesentery. Looked to me like carcinoid, probably more likely lymphoma. I couldn't exclude carcinoid. You could think about something like Castleman's, gives you mesenteric masses that's slightly enhanced, but that would not explain the small bowel. You can go through metastatic disease, maybe a renal cell, but didn't look like renal cell. The kidneys look normal, so that was easy. It ended up, amazingly, to be IG4 related. We see a lot of IG4 disease, and we typically think about the pancreas, autoimmune pancreatitis, or this patchy, wavy shape enhancement of the kidneys. But IG4 can involve many things in the GI tract, from the esophagus to stomach to small bowel to colon. And this was IG4 involving the terminal ileum, simulating a mass or a really bad case of Crohn's disease. When I went to the literature to review it, and when I used AI Copilot, I found that this has been reported. It's more common in the small bowel. And the point about it, although it's rare, can be confused with IBD, most typically Crohn's disease, but also can be confused with a neoplasm. So it was a great case. So it made me think of other great cases. Think about really thickened small bowel and prominent vessels. I showed one of those cases yesterday. Well, you could think of really edematous bowel and prominent vessels. You could think about graft versus host disease, most common in the ileum, but the patient would have had a bone marrow transplant. You could talk about patients on medication. ACE inhibitors give you severe edema. In fact, it's angioedema of bowel, usually more distal bowel, and also with prominent vessels. We talk about, what else is unusual? We talk about Crohn's disease. We talk about infection this time of year, which is the summer. Infection like salmonella, enteritis, really thickened edematous bowel, patient with severe diarrhea, often prominent folds. We talk about Shigella. TB is a long shot. You can see strictures in the bowel, a so-called reverse umbrella, but not all that common, just simply markedly thickened and dilated bowel. That would not be a good hallmark for Crohn's disease. You could think about other infection nodes in the mesentery and small bowel abnormality. You could think about MAI infection, but MAI gives you a fluffy bowel appearance. This was more mass-like, I have to admit. And the terminal ileum, again, you go with Crohn's, you go with lymphoma, you go with salmonella infection. We can talk about other things as well. We talk about ischemic bowel, pneumatosis perhaps, edematous changes, potentially small enhancement. We look at the vessels. Again, when you have ischemic bowel, you typically have vessel occlusion, whether it's SMA, SMV, celiac, or its branches, but you look really, really carefully. When you're talking about drug-induced, then the bowel looks good. It particularly, not that the bowel looks good, the vessels look good. And if anything, you see really prominent vas rectum. Because of the edema, you have hyperemia and increased flow. There's no vessel occlusion. It's just the vessels are going in. So it's a really good thing to think about. When I think about small bowel, I always think about the ideas of, hey, pick normal versus abnormal. And then after you pick normal versus abnormal, then you can be more specific. Again, with small bowel, you think about tumor, you think about ischemia, again, older patients, you think about infection, good thing to think about. With the history driving you, you think about graft versus host disease. We can look for things like omental infarcts, malrotation, all sorts of other possibilities. So what else? Those are the main things. I guess I was trying to look at my computer and see if I could answer any questions anybody has, but I've pressed a button which shows me a bunch of current viewers, but I can't see the viewer's name, so that is somewhat annoying. In CTisus on the teaching file, there are a lot of cases of bowel pathology, whether it's tumors like GIST or carcinoid, adenocarcinoma or lymphoma, whether it's inflammatory bowel disease like Crohn's, whether it's ischemic bowel, whether it's infectious etiologies. All of these possibilities are illustrated at length. And to me, the best way is look at a lot of cases. Again, when you're looking at small bowel, look at the bowel, look at the segment involved, dilatation, stenosis. Is it tumor or just inflammatory? What about the mesentery? What's the mesentery doing? What's the vessels doing? Are the vessels patent? Is there increased hyperemia? What's going on? I think the point is, when you're looking at bowel, look at everything. Vessels, mesentery, coronal views, and MIP imaging. The whole 3D process becomes very valuable in many of these cases. So I would spend some time looking at that as well. So those are the main things. Again, we have some lectures online and I will do some more. So with that, I hope everybody has a great day and I'll see you next time. Bye guys.